Yeah. Good afternoon. My name is Karen Gordon, and I'm a member of the Education Committee, and I'm delighted to welcome you this afternoon to Close Encounters of the Unprofessional Kind, outreach efforts about sexual misconduct and boundaries. In this session, representatives from the Federation's Sexual Misconduct and Boundaries Committee will hold a panel discussion on the latest findings and research related specifically to the field of physical therapy. The speakers for this session are Michael Noonan, Mira Mariano. I practiced a while ago and I've already messed it up. Okay, and Samantha Moen Johnson and Sherry Peru. They are all members of the Sexual Misconduct and Boundaries Committee. You'll find their bios in your event app, so we won't go through that up here today. They have valuable information to share, and they also welcome and encourage your participation. If you wish to ask questions during that last 10 minutes of the Q&A session, the members will provide you, the Education Committee members will provide you with a microphone. This session is going to be recorded, so before you ask a question or make a comment, make sure that you have a mic. At the end of the session, as all the sessions, please scan the QR code that's on the actual slide, or we have a piece of paper at the back that has the QR code, and give us your feedback. Now, if there's not anything else, I'll turn it over to the presenters.
Thank you, Karen. Hi there, I'm Sherry Peru. I am the chair of the Sexual Misconduct and Boundaries Committee. I have 3 of my fellow members up here with me. I wanted to acknowledge the rest of our committee: Jason Kaiser, Stephen Curley, Carolyn Taylor, who is our public member, and our board liaison, Ellen Donald, and Leslie Adrian, who without her, this committee would not function. So thank you to Ellen and Leslie. This is a wonderful committee. We have done a ton of work this year. We had 2 in-person meetings. I adore every one of these people. I'm pretty, if you can't tell, I'm pretty vertically challenged. And I am wearing Samantha's shoes to make me a little taller. So that's how much we all love each other, that she passed me her shoes to wear, and they're definitely not my size. So I'm not moving. Also, when I was making the slides for this presentation, I'm a New Yorker, if you can't tell by my accent, although I live in Oregon. I was thinking I was going to watch the World Series this weekend while I was here. Not happening, which is kind of okay, I can focus more. But then I was reminded by several people that we're also in Iowa, in the land of the Field of Dreams. So I feel a little better about having the baseball slides than I felt last night. So the charge of our committee, the Sexual Boundaries Committee, I talked a little bit about it this morning, is to promote the awareness of sexual misconduct and boundary violations to the membership and create educational resources. We have already developed a ton of resources for boards, for licensees, and for the public, and we're working on even more. We worked on some this year, and we have some great projects that we're still working on. Like any wonderful Federation presentation, we're going to have Slido questions. So I'm assuming everybody's already knows how to use the Slido, but if you guys can get prepared, we're going to have some questions towards the end of the presentation that I will come back up and talk to you guys about. Give everybody just another second. So we're going to spend some time in this presentation kind of talking about the past, what we worked on already in this committee over the past few years, starting from a task force until when it became a committee, what we worked on this year, our present, and then what our goals are for the future. One of the things that I am super proud of is our power imbalance white paper that we developed last year to really help people understand the power dynamics and the power imbalance between patient and provider. The white paper is accessible on the member resources page, and we also have a hot off the presses video that you guys will see that hasn't been shown ever before. I actually just saw it like a couple days ago. We're really excited about our videos, and we have more videos that are still being worked on. The other thing that our committee did, feels like a long time ago, was we took a really deep dive into looking at all of our websites to see what are the barriers to people filing complaints, and what do our complaint forms look like, and is there anything on your complaint form or on your website that would prevent people or deter people from filing a complaint. For example, some states have a clause on their website that says, this complaint form will be given to the licensee that you're filing a complaint about. Well, who's going to want to file a complaint if they see that? Or some states take many, many, many clicks before somebody could even find the complaint form. So we really took a deep dive in looking into that, and then the rest of my presenters will present some information of some research that was done by HRRI, kind of looking into what can we do differently, and some audit forms that we can pass out to you guys to really be helpful with. So I'm going to hand it over to Samantha. Samantha's going to go over past, then we're going to pass it to Mira, then Michael, and then I'm going to come back at the end.
Oh, look at, we did this again.
Excuse
Just gonna get dressed here. All right, so I get the easy part. I get to talk about some of the things that probably a lot of you are already familiar with. And a lot of this information is out on the poster in the hallway, and then also available on the resources page. But I think the first thing that the task force and now this committee has done is just to increase awareness of the importance of this topic and the fact that this is something that is really happening in our profession and something that we need to be aware of as regulators. As Sherry mentioned, the resource on power imbalance, that white paper is available in the resources. And then we've also created a number of infographic documents, and I'll kind of walk you through those. This first page here, we just wanted to kind of make sure that people understood how to find the resources. So probably the easiest way to find our resources is honestly just to Google FSBPT Sexual Boundaries Committee resources, and bingo, they come up. This is all public information, so anybody should be able to access this information. You can also go to the website, just go to fsbpt.org/resources, and again, it'll bring you right to where you need to go. And if you're here at this presentation, you can also use this QR code, handy dandy, it'll bring you right there as well. So some of the resources that we have developed so far, we've really tried to take a holistic perspective and think about who are all the stakeholders that we need to think about. So we have resources that are aimed towards providers, we have resources that are aimed towards patients and the public, and we have resources that are aimed towards boards. The first one that's listed on this slide here, I know it's kind of hard to read, but the first one is the board resource page. And this is essentially a comprehensive list of all kinds of information for boards who are wanting to know how to remediate, how to look at potential resources, how to how do other boards address these issues? How do other professions address these issues? And so there's just a list of, comprehensive training programs and other resources that are available that way. The next thing that we did was we spent about a year, I think, working on developing some infographics. And like I said before, these are really aimed towards a variety of different stakeholders. The first one that we're showing here is geared really towards the provider. And so it's got some information related to that power differential, the fact that there's automatically a power differential because the provider is the expert, right? The patient is coming, they're looking for your services, they're in a vulnerable position, and it is your job as a provider to really recognize that imbalance and make sure that you're taking steps not only to protect your patient, but also to protect yourself, and make sure that you're protecting your license in that. Additionally, talking a little bit about the therapeutic relationship. What is that built on? How do we maintain that therapeutic relationship? What are the threats to that therapeutic relationship? We also included some descriptions of what does sexual misconduct look like. I think the things that feel obvious to people, like participating in sexual activity with your patient, yes, it's on this list, but it's all those little things that lead up to that as well, that are part of that whole concept of sexual misconduct. Additionally, we included some information about informed consent, being that that is a huge part of the process that any provider should go through, especially with any procedures involved with touch. And we're a high-touch profession, and so making sure that that really hits home for providers as well. This is my favorite part of this resource. This is kind of our stoplight system. So this is just a list of different behaviors that clinicians engage in. And you can see kind of the traffic light example here of the green behaviors. Those are ones that you should be engaging in as a provider. The red ones, not so much, right? And I think the yellow ones are actually really important because that's where it kind of tells you, ooh, my boundaries are starting to drift. I need to do some checks and balances on myself. I need to kind of get back into those green level behaviors. The second resource that we have is geared more towards our patients and the public. So again, there's information about informed consent, but more on kind of, what are your rights, what are your responsibilities, what are the responsibilities of your provider in terms of what they need to share with you and make sure that you really understand the value of PT or the intervention that you're engaging with. Also some information about what to expect and also more importantly, what not to expect during a physical therapy encounter. So again, just some examples of some of the things that we've already come up with. As Sherry said, we have a video that is hot off the presses here. And this relates back to that concept of the power imbalance. And so we're going to take a few minutes to share this with you.
Every decision that a physical therapist or a PTA makes, they need to understand that there's a power imbalance there because that person's vulnerable. They're looking up to that professional for help.
We try to explain to students in educational curriculum to always think about that power differential of the patient-provider relationship and not putting them at risk for blurring that boundary or crossing that boundary.
The delivery of healthcare today isn't done with a doctor the way it was 30, 40 years ago. In fact, today you might see a doctor for 10 minutes total. What you will see is maybe a nurse practitioner or a registered nurse or a physical therapist for that matter, for hours on end.
People go to physical therapy because often they're in pain or they're not able to do the things in life that they want to do. They're already vulnerable. And if they're going to go to see a physical therapist, the physical therapist should know this about their patient and know that they have to be very conscientious about those boundaries.
When we go into that situation, there is inherently a power imbalance or a dynamic that you should be aware of, both the PT and the patient. You are not walking into this scenario with a patient on the same playing field.
Think about what you know about your patient when they come in to get therapy. You've looked through their chart. You know how old they are. You know what medications they take. You know their social history. You know their medical history. You know all these things about them. They don't know any of that about you.
You have this education that you understand how this medical history or this past illness or this past surgery relates to their current issues. Your name tag, the way you dress, what you're wearing, scrubs, professional attire, all these things play into it. And then when you start, talking about, we're gonna use this to treat you, or we're gonna use a traction board, whatever it is, they don't understand what they do or how they work. So all these things build up into more and more of an imbalance between you and the patient.
I think it's really easy to just assume people know more than they do.
When patients come in, they don't always know how this relationship is going to play out, and they also have anxiety about whatever appointment is coming up.
That patient might have a history of some kind of victimization in the past.
Patients may be more vulnerable if they've experienced trauma before. They may be more vulnerable if they have feelings of insecurity, or if they're not comfortable confronting issues. If they have mental health issues, they're more vulnerable. And so you don't know who's coming in that door.
The responsibility falls on the physical therapist.
Sexual misconduct and sexual boundaries is a little bit murkier water, and sometimes you actually have two victims in the matter. So you have a sexual misconduct situation happen between a licensee and a patient, and it may appear at first glance to be consensual. You don't realize that that power dynamic essentially nullifies that consent. When that happens, it may be that the victim in the matter doesn't even realize they're the victim yet. That's inappropriate. There's a power dynamic there that needs to be accounted for.
The physical therapist really has to understand that they're in a role where that patient is looking towards them for the best healthcare advice or the best treatment. That involves explaining to the patient what that visit is going to entail and explaining the details of everything that's going to transpire during the visit. If there's good communication, it relaxes the patient, they know exactly what's going to happen.
I think it's very easy for therapists to forget that that power dynamic exists and that we are always not at the same level of the patient.
Every decision that a physical therapist or a PTA makes, they need to understand that.
You don't want to see that again. Okay. I'm Mira Mariano from Virginia, and I'm going to talk about the present, so what our committee has been doing this year. And we've actually been really, really busy. So last year we spent creating those different documents for the different stakeholder groups, many of which you indicated that you wanted and needed at our LIFE meeting last year. And many of the things that we did are on our poster in the hallway, which Sherry talked about earlier in the presentation. So if you get a chance today, please check those out. They're out there in the foyer. So we created those different brochures for the different stakeholders. And so one of the things that we really wanted to do was create an infographic for students, because as you've been hearing about all weekend is the big student webinar that's coming up next week. But we all know that sometimes students actually don't really read the textbooks. And so we said, how can we present this information in sort of an easy to digest infographic that's colorful, that gets the point across without appearing to lecture to them and give them, different 5-page handouts and things like that. So we took different pieces of the brochures that we had already created and formulated sort of a 3-page infographic that talks about all the similar concepts that were mentioned in the previous stakeholder brochures. So we talked about this patient-provider relationship being on a continuum from, power differential, and also we included the concepts of informed consent, because we all know that as an educator, we talk about informed consent at various points in the curriculum, but sometimes the students don't always verbalize those things. They're so task-oriented with wanting to practice whatever the task is, but sometimes they don't always practice the verbiage like they would with a patient. So continuing to sort of emphasize those concepts, and that informed consent isn't something that you just do one time on the initial evaluation. that you need to continue to explain new techniques, new procedures, and make sure that the patient really understands what they're going to have happen to them. And then, of course, again, Samantha talked about our sort of traffic light categorization of behaviors. Students get that. They know that they definitely should not be in the red zone, and it's a slippery slope when they start getting into the yellow zone. So we added that. And then new to our students is sort of suggestions and tips for how students can deal with inappropriate sexual behaviors. Because this is something that doesn't always get verbalized on the post-clinical experience assessment forms, but we do know that it's happening. In fact, in a 2017 study by Bill Boisnel et al. And his group, they actually looked at inappropriate sexual behaviors experienced by PT and PTA students and clinicians over the course of their career, and it was a whopping 84%. And then when they asked the same question about that, those same people, have they experienced inappropriate sexual behaviors over the last 12 months, so just in the previous year, it was 47%. So almost 50% of our students are experiencing these things on their clinical experiences, but yet they're ill-equipped on what to do with it. So what do you think is the most common response that students would do when they experience this? Exactly. Somebody said ignore it. I'm just going to ignore it. Maybe it'll go away. Maybe that really didn't happen. Should I tell my CI about it? Should I not say anything? Oh gosh, hopefully I don't get the same patient tomorrow, right? So it gives them a lot of stress and anxiety. So we thought that having a discussion, having students have this discussion with both their faculty and their clinical instructors is always a good way to get mentorship and get tips with how to deal with those behaviors. And then finally, social media. So we know that our students are in a different generation. They've grown up with cell phones, right? They've grown up with social media, and sometimes they don't understand how to sort of keep separate the personal versus the professional portion of their social media pages. So this page goes through different ways that they can handle those social media interactions professionally. So Sherry already talked about HRRI and our efforts of our committee with funded research with Catherine Dower, and we talked last year about the paper that was released with communicating about physical therapists' sexual misconduct. And last year at the annual meeting, we presented our findings, and also it was a preliminary audit form that was released, which we subsequently revised, and we have in our final version this year. So this particular audit form is pretty short. I think it's 3 pages total, and it's a way that different regulatory boards, it doesn't have to be just physical therapy, but different regulatory boards can actually go to their website and look, is your complaint file easy to find? Because in Catherine Dower's research, some of the websites, it took multiple clicks to even find the complaint form. And that can be a huge barrier to somebody even filing a complaint. The other thing is the verbiage clear? Is sexual misconduct actually listed on the website, or is it all under the umbrella of unprofessional conduct? So check out the audit form. They're free, they're not mandated. We feel like it's a great way for you to take this information back to your boards and be able to sort of do a website review to look at a lot of the things that we've looked at. We actually, in our meeting, did our own respective states, and I think Leslie had us pick a random state to use these audit forms. And it's super easy to use because, again, we're following that red, green, yellow traffic light example with, yes, it's there, it's easy to find, or no, I absolutely can't find that information on that site. So seeing that so many of our boards differ, we figure here's some tips on how your board can utilize the forms. So if your board has a work group session where they can sort of divide up the work and go to different portions of the website to utilize the audit form to see, are these things easy to find? Is the language clear? Are there a lot of euphemisms that are used on the website? Maybe your board has a retreat or a strategic planning session that you can take an hour to kind of use the audit forms. But pretty much the rationale for the audit forms is to be able to improve the websites and make things much easier for the public. And then finally, our second video.
I don't think providers realize how much influence they have with their patients. I think some of us think, oh, we're just physical therapists, but that actually comes with a lot of weight.
Licensees, students, you never think something is going to happen to you.
In physical therapy, we develop a very direct relationship with our patients. Some healthcare professionals, it's at an arm's length. With us, it's one-on-one most of the time. And in that, there's an inherent relationship that develops.
The goal is to educate students that there's more to physical therapy with this whole patient-provider relationship.
I think physical therapists need to appreciate that how we're trusted comes with a really high level of responsibility. Sexual misconduct in the workplace is anyone who's doing something other than what they're supposed to be doing, touching a person in the wrong way, speaking to a person in the wrong way, introducing sexual language, sexual innuendos, sexual jokes. It could be your patient, it could be your patient's family member. There's no room for that.
Even though we're a very touchy manual therapy profession, sometimes they never think that something that they're doing could be misconstrued in a negative way.
You are responsible. It doesn't get shifted onto the patient. You're responsible for putting the brakes on when it comes to anything that could be construed as sexual misconduct in the workplace.
I think it's always important to recognize that there is a boundary between the provider and the patient, that your role as a physical therapist or a physical therapist assistant is to help the patient achieve their goals related to the problem that they're coming in for. It's not being integrated into their entire lives. It's not creating a lifelong relationship. It's helping them out in like a snapshot of time.
Students need to think about it right off the bat and recognizing that the bar is now even higher when it comes to a patient.
Because of the training of physical therapists, it's very task-oriented. Without proper communication, proper asking and getting consent where you're putting your hands on patients, it can get pretty sticky if any of those steps along the way are missed.
By the time they're ready to go out into practice, they may not be perceptive enough until they're confronted with the issue. Then there it is right in front of their face. They realize, oh, this is one of those experiences that they told me I might have. We try as much as possible to get them to think critically. What is the best thing for me to do at this moment, and what is in the best interest of the patients to protect them?
I think it's always in the forefront of the physical therapist to remember what they're doing, why they're doing it, how they're doing it, if it's okay if they do it with these particular techniques so that there's no misunderstanding.
You have to kind of be really aware all the time. I think it could happen to any of us.
I think we always all have that ability to be someone who violates those professional boundaries based on what's going on in our lives.
Preventing issues, it puts you in a better spot. I'm going to put in place making sure that I gain informed consent, that I explain what I'm doing to my patients, that I ask for a third party to be available if I feel uncomfortable or if my patient is seeming uncomfortable.
Communication is probably one of the biggest things that we see in many of our cases. And if the provider had just communicated what they were going to do, why they were going to do it, all those things, then there wouldn't be a complaint filed against them.
By starting those habits early and doing them ahead of time, you're not having to justify the choices that you made, not having thought about them.
With students, I think a little bit of it is exposure. And knowing that it's not just about a technique that they passed a written exam, that there's more to physical therapy with this whole patient-provider relationship. It is a professional-patient relationship, not a social friend relationship.
We all have our different boundaries in our personal life, but in our professional life, there is only one boundary. Your patient is your patient. You are a PT, and that there's a line that's very clearly drawn, and state laws address that.
With regards to students, we teach them to embrace the responsibility of being a physical therapist, but also keeping in the back of their minds, like how you deliver that care makes as much of a difference as the actual care that they're giving as well. Always remember the role that you play in your patient's health care, and always remember that those are the things that will keep you practicing for a long time into the future.
So that was the second video that really we wanted to highlight that patient-provider relationship, especially for student clinicians, but the video really could be used for anybody. So hopefully you guys thought that we got our messages across.
I don't think providers...
Oops. I just wanted to let you guys know we've had a busy fall. 2 weeks ago, Samantha and I were at ELC and we presented a 90-minute educational session at the ACAP APTA ELC meeting called The Touchy Subject. And so it was pretty interesting. We're going to talk about one of the scenarios that we presented because earlier in the conference we talked about an educators module that our committee has been working on so that educators can take portions of the module and tailor it to fit their programs. And it would have a pre-test, a post-test, a slide deck, talking points, case scenarios. They can utilize all of it, some of it, however they want to fit their own particular programs. And then we also, Sherry had a presentation, and Michelle Sigmund-Gaines and Catherine Dower and I presented at the CLEAR conference in September as well, more broadly to a really international group of regulators on the subject of sexual misconduct, which was very well attended. So, I'm going to give you a minute to take a look at this scenario. This was one of the scenarios that we actually had in a group of maybe 5 scenarios in our ELC presentation. And these scenarios were actually developed from real situations from our committee members. And so we just picked this one. And it's a rural, small-town community. So I'll give you a minute to read through the details, the dirty details. And so, of course, we presented it via Slido, and we said, is it okay for the patient and the PT to be in a consensual sexual relationship following discharge? So we're going to give you all a chance to answer that question as well. So I'll give you guys just a couple more minutes. I'm not sure how many people there are in here, but we have 49 responses so far, so I'll give you a little bit more time. So 60%, I don't know if that's overwhelmingly, but definitely in the majority, you all, as regulators, say no, which is the correct answer. However, we posed the same case at ELC, and this was the responses that we received at that conference to a group of educators who self-selected coming to our presentation. So what do you all think of this difference in response? Interesting, I heard. Yes. Yeah. Wait, hold on one second for the microphone. It's right here.
I just wondered if this is actually encoded in our Practice Act or our rules, is one question about it. And the second is I saw a lawsuit that it wasn't a PT but another medical practitioner who was cited for having multiple relationships with patients after he had discharged them. He sued and won because it wasn't spelled out that you could not, or how long after you cut that relationship and that kind of thing. So I wonder if we have this very clearly defined as being an absolute no.
So that's an excellent question, because we have our code of ethics, right? We have our white papers and our resources that say one thing, but interestingly enough, not everybody has in their rules, statute, regulations about when that patient relationship ends. There's some jurisdictions that say it ends at discharge. Some don't say at all. Some say 2 years. Some say 30 days. Some say 5 years. So it's an interesting discussion point, and it was definitely interesting for us to get this response at an educators meeting. So clearly we have more work to do, right? Which leads us to the future and Michael.
Hi, my name's Michael Noonan. I'm from Rhode Island, and I'm going to talk about the future. But before I talk about the future, I first have to digress a little bit. O'Day had talked about the other day about everybody having accents and stuff. And I grew up outside of Boston, just outside of Boston, and you might think I have an accent. I don't think so, but you might think I do. Okay, I'm going to help you out. There's an app. It's called Google Translator. Bring it up and use it. Otherwise, you might run into Clarence, who's 12 foot 6 inches high, and then you'd be in trouble. Anyways, I'm the newest member of the Sexual Misconduct and Boundary Violations Committee, and this is my first time speaking at the FSBPT. And if you wanted to say a part of me was a little nervous, you're right. It is. I'm a bit nervous in part because I serve with an incredible team on the committee. And I'm sure some of you have been here for a while. Think back of when you first began. Nervous. Not only nervous, but how am I ever going to know what these guys know? It's so much information. And I think they stacked our committee. I really like to say it's a nice committee to begin with, because everybody on the committee and everybody in the FSBPT have been extremely supportive and helped me feel more comfortable in setting in and such. I would recommend for you to volunteer for the FSBPT. It's one of the best organizations I've ever been involved with and such. And really, everybody in this room, we're the future of the FSBPT. So that's my transition into the future. So some of the things that we're working on, upcoming projects, is the educational model for educators and students. This will include various components that educators can tailor fit their respective PT and PTA programs. All the content needed will be provided, and you just need to tailor it to your current curriculum. The target date for this to be done is the 2025 academic year. And so you don't have to do all the work. It's already been all prepared for you. It's going to be an excellent thing. The second thing that we're going to talk about in the future coming up is testimonial videos. Not my testimony, but of real licensees who have been subject to a board complaint. They're going to talk about their actions. They're going to talk about their experience with the board and what they learned in the process and how this has changed them. I'm really looking forward to that. It hasn't been done yet, but we're moving towards that, and it'll be quite insightful. I've been a therapist for 45 years. I wish this information was out there when I began. There's so much stuff that goes on, and if you're on the licensure boards, you see the things that are going on. And so it's great that it's being addressed and that things will start to hopefully change. The third thing is on November 6th, there's a webinar for students and educators. It's at 7 p.m. Sorry. And it says, this is the slide, it says, as the future healthcare professionals, it's a matter of when, not if, you will experience difficulty or inappropriate situations. It's essential to understand the importance of maintaining ethical boundaries and preventing sexual misconduct in physical therapy. You saw earlier how they had the green, those are things that you should say, the yellow, oh, you're starting down that slippery slope, you shouldn't be doing that. And then the red, you've already crossed the line. It's, time to do something. And I think a lot of people don't even think about it. They think about, just, oh, I got to text this patient of mine. They're so nice. Let me just see how they're doing and what are they doing tonight? You can't do that. You'd be surprised. This is the FSBPT's first website geared towards students, and we're all very excited about it. We heard at the Educational Leadership Conference that many programs were already aware of this webinar because they had received an email from their board and received info from the FSBPT. Can I just ask for a show of hands, how many people have already registered for this webinar? Excellent. And how many, show of hands again, how many have shared this with an educational program within your jurisdiction? Excellent. Excellent. Well, I encourage people to come to listen to this webinar. I encourage you, if you know the educators in your state, to be able to call them up, whoever is the head of the program, and to tell them that this webinar will be coming up and actually to have the students look at it as well. You can registration, you can either do the little QR code right there, if you like, or if you're not, you can go through this process to register for the webinar. It's the www.fsbpt.com. Then you'll go to news and events, and then events, and finally, guess what? Webinar. Okay? So I hope that you can join in on those. It would be great. Because the last thing that I have to talk about, whoops, not that one, is collective feedback from jurisdictions for future projects. Collecting feedback from jurisdictions for future projects. Rhode Island Licensure Board, I want to just talk to you about for just a little bit. It's under the Department of Health. It's nearly impossible to make a change. I had brought something back from one of the meetings about how they do the discipline and try to get continuity about discipline. Virginia had done this. They took 10 years of data and come up with this form. So I brought it back. It had to go up to the director of the Department of Health, who said no, and come back down again. So it really limits what you can do. Everything flows from the top down. And there's limited staffing. Our administrator of the board administrates 11 boards. All the money that comes in for licensure for the physical therapy, you think it would come to the physical therapy licensure board to determine? Nope. You think it would go to the Department of Health so that they could determine? Nope. It goes into the general fund so the politicians can then decide how to spend the money that they've collected. And so, you know, everything's a little bit different. One of the PTs that had come to a LIFE meeting ended up coming back and shared what they learned about sexual misconduct and the boundary violations at the Rhode Island Licensure Board meeting, with the hopes that they would make some change. From my perspective, that's progress. To get information from the FSBPT, to achieve dissemination of that information to the state level, and to make positive changes is a major goal of the Federation and of this committee. Now I'm going to turn the presentation back over to Sherry, who will who presented at the LIFE meeting and will share some of the responses from the attendee. Thank you.
I think Michael's lying that he's never given a presentation before. What? No, I'm on my tippy toes. So I want to talk a little bit about the LIFE meeting. I presented some information, not as much detail here, to the group that attended the LIFE meeting. And we gave some polls out to the group, because what we really want from this committee, which is, I'm assuming, what most committees want, is to get feedback from the attendees to say, what do you need? What can we do for you? What will be helpful? So I'm going to throw out 3 different Slido polls to you all, but also give you the feedback that I received from the LIFE. And even if you see something that's like, it's already there, please just share it again, because the more we see a topic, like at LIFE, I think the thing that came up the most besides AI and workforce data was informed consent. Everybody wanted more information about informed consent, and the Informed Consent Task Force will be presenting tomorrow as well. But we asked the question, what topics do you feel need to be a priority? We had tons of responses: informed consent, patient interactions like we had in the videos, clinical practice and professional development. I was really excited about feedback on working with different special populations and sensitive topics, ethical considerations and legal implications, like what are the implications of filing or not filing a complaint, or, you know, licensee's duty to report. So I pose the same question to you all. What topics do you feel need to be a priority for this committee that would help you in your jurisdiction? So I've got informed consent resources, boundary violations in rural settings, defining patient-provider start, and more importantly, the end. We brought that up before. Investigating complaints, creating an environment that limits the potential for sexual misconduct. I love this patient contact post-discharge. That's kind of come up quite a bit. Assertiveness training, education, generational differences. That's a big one. This is great. Thank you, guys. Research on current occurrence of reoffenders. We're actually looking at that. The length of the relationship. Clear definitions for when it's acceptable to date a former patient. I see a lot of this. When does that relationship end? Who's a patient? Social media. Thank you all. So the next question we asked is, what additional resources would you like to see? We had a lot of responses. We put them into a couple different categories: remediation and education, such as, there's a lot of good remediation courses out there. Most of them are really expensive. So people were asking, are there any good remedial courses that maybe are effective but don't cost as much? Communication strategies for the patients, for the public, legal and investigative practices, like it comes up for me a lot, like when to inform or work with law enforcement and when should they be involved. Practical tools and materials, such as like less expensive resources that maybe we can access. And then public relations and board transparency, such as social media campaigns and educational videos. We have a really broad group on this committee from various different states. In some states, Jason from California, they do all kinds of TikTok in California. We don't do that. So just, how can we get stuff out there, and what's the best way to do it? So I pose the question to you all, are there any additional resources you would like to see developed by this committee? Legal infographics. I like that colleague-to-colleague sexual misconduct scenarios. Videos are really powerful. Mentor-mentee relationships. Webinars geared towards employers. More educational videos that can be viewed on YouTube and TikTok. You hear that, Jason? Our TikTok expert.
This is just kind of a shameless plug, but before the poll closes, could we get maybe a little bit more clarification on what you mean by legal?
Yeah, I was going to say the exact same thing. So if someone who put legal wants to speak up, that would be great.
While you're waiting on responses, is the webinar going to be recorded? Because like a crazy educator, I'm giving an exam the next night, and I'm confident that no student will watch it. Will it be recorded, the one that's happening next week?
Rich is nodding yes, it will be recorded.
Okay,
Yes.
that is awesome. Thank you.
Anybody who put legal up there want to give a little bit more clarification on what that is, or if not, find us after any one of us and chat with us, because that would be great. And then the last question is, what video content would you like to see developed? Those videos, I have to say, filming those videos is a little stressful. They just took us all in a room and asked us a bunch of questions, having no clue. I felt like I was on one of those, I witnessed something on the news. And I had no idea what they were going to take out of what I said. And up until like 3 days ago, I was so anxious of what is that guy going to take out of what I said. And I think they came out great. So I think I went to the Federation of State Medical Boards. I presented at their conference in April, and there were some presenters from Australia, and they had some videos from real licensees who had been through investigations. And we had already made the decision for us to do that as well, and it was so powerful to me. Like, I can say whatever I want. I can come up here and talk about it. Any of us can. But to see someone who'd actually have really been through that and talk about what was my experience with the board, and what did I do, and why did I do that? I know I shouldn't have done that, and what did I learn from it? It really was so powerful, so I'm really looking forward to. And we worked really hard to get people who would agree to do this. So that was hard too. We had a whole group of, oh yeah, we have this idea, this idea, this idea, but then you have to get somebody who's willing to do it. So what video content would you like to see? Informed consent, big one. Social media, more on the power dynamics, more educational tools. We have legal and ethical frameworks here, like explaining, like HIPAA and the implications of in healthcare settings. I've had a lot of cases the past couple of years about HIPAA, like people going in and accessing patients' files that they shouldn't access. And why is that a boundary? And why is that something you should not be doing? So I think that's a great suggestion. So what additional video content would you guys like to see? Acting out cases, social media do's and don'ts, I love that. victim testimonials. That's a great idea. Patient communications that blur the lines. Student testimonials. Malpractice insurance versus regulatory, I like that. Social media, a lot of social media. You know, it's interesting, I think it was 2009, I produced some really low-budget videos with Annette English and Nancy Kirsch that we filmed on our own. And I've gone back and looked at them so many times, and the material is exactly the same as material we would use now from 2009, other than the fact that we have a flip phone and a BlackBerry, and we're talking about, I think, Facebook, like it just came out. We're like, oh, I have a Facebook page. Do you know what that is? You know, those kind of things. But still, like the content of the videos, not much different. So we have probably about 10, 12 minutes for questions. We'd love to hear, if you want to bring something up now, find any of us anytime during the meeting if you get some ideas that you would like us to look into. This committee loves to work, and we have a lot that we know people still need to learn. But I'm really, really glad that this is something that's talked about so much. I'm so happy about the Informed Consent Task Force that got developed, and that's something that I think is going to be a great, great resource for everybody as well. Here comes a mic.
Thank you all for your work. This is amazing. And I'm putting on my educator hat, and I'm thinking about the webinar next week. And I'm also in clinical education. So my question is, during the webinar, will there be reference at all to Title IX for the student who might be on a clinical experience that has some inappropriate behavior by a patient towards them, or comments, et cetera? So I didn't know if that was a part or if it was beyond what you were discussing, but it would help me to know that as I'm encouraging students to watch.
You know, honestly, I don't know that we've talked about that at this point. I think it's a good idea, though, as far as at least saying something about the fact that, you know, this is a resource that's available to you. You need to know about your rights, and I think we could probably pretty easily weave that in.
That would be helpful. Thank you.
I appreciate that comment.
Yeah.
Michelle from Wisconsin. Oh, kudos. Just amen and kudos to you. That's just fabulous. Speaking as a professor emeritus, an older faculty, are you sensing any disparity, any differences between younger faculty and their counseling of students versus more seasoned faculty that may or may not come from a regulatory community?
I'm going to pass that to the people who work with students.
I think there's probably some variation, almost more on content expertise. I can say that I think in our program, I teach like our psychosocial content, and it's definitely something that's on my radar. We talk about a lot. Our professionalism content, I think it gets talked a lot about there. I don't think it's weaved in as well as it could be in some of the other areas where students are actually, you know, engaging in examination procedures, disrobing, some of those kinds of things, where it maybe could be reinforced to just start those good practice habits earlier. You want to add?
So I'm pretty fortunate. In my position, I get the newbies. So I start them off in the summer, and you know, that whole anxiety in the lab the first time they're asked to disrobe into their lab clothes. So obviously we talk about the language, but then we make a pretty concerted effort that in every lab course, including the professionalism courses that we're talking about, touching people, working in sensitive areas? Do you want to chaperone? Because I think what happens is the students get so comfortable by the third year, they're like half naked in front of each other and they don't even think about anything. So, but I do notice that with some of our younger faculty, we have to sort of remind them about, doing the verbiage, saying the things, instead of just going and doing the tasks, doing the skills. But I think that they're very aware because they've all practiced themselves. And then we do have a fair amount of faculty that do pelvic health. And so with pelvic health, TMJ, anything where you're working in an orifice, that's a whole nother area of sensitivity that requires language and communication that goes along with it.
I can add along the same lines. I think what we're seeing is people are learning more and being more aware, right? After the Me Too movement and all this, people are definitely being more aware that they have to ask permission to touch someone. What I see as an investigator and what I've seen in some of the research that I've looked at is the people who are offending. I mean, you have different things with new professionals, social media, things like that. But it's older people who have been in practice for a while, maybe solo practitioners who don't have anybody there to ask questions or to say, hey, maybe you shouldn't say that. Maybe that wasn't the right thing to say. People who don't have guidance from other people or who have maybe been practicing for a long time and they kind of go on that autopilot that they don't think they have to say it because they've seen 500 patients with that diagnosis. And to them, it's just, another shoulder or another back. And they don't think it's necessary to explain it, or they over-explain it so much that the patients are like, I have no idea what you just said because you used big words that I don't understand. I also want to thank Michelle because she started out on this committee before she got on the board. So a lot of this pre-work you were very involved in, so thank you.
So, Tina from Alaska. So I as we're talking about all of this, and first of all, thank all of you. Excellent presentation and things that I think seasons our young therapists need to be thinking of. But one thing that comes to mind is adaptability of the therapist with regards to age-related cultural or religious differences between patients and how our touching or our speaking to them is perceived in those various diverse groups.
We've talked about that a lot. Thank you.
Oh, hello, hi. This is Wanda from APTA, the lover of your dog. I was just curious. APTA receives all sorts of calls, and we just received a call from a student almost exactly about that scenario, where a CI was trying to expose the SI joint, and I guess the student either wasn't prepared or perhaps they had not had that discussion, et cetera. So I'm assuming that your resources do help to inform that. And then I guess my question, I guess selfish perhaps, is we suggested that the student contact their school, their, I guess, the leader or the dean or chair, et cetera. Would there have been any other recommendations we could have offered that student member? He seemed very concerned.
I always say the same thing. I refer the students to the school, and then the school would refer them to us. So we're trying to work with our schools. I have a really good relationship with our PT and PTA program to say if something happens with a student, they don't just come directly to us, right? Report it to the school. The school could bring it to us, and then we could work together on that. But yeah, it definitely happens. I've had several cases like that. And think about a student. I mean, I remember when I was back in PT school, the last thing I want to do is say something. I just want to graduate. I want to pass that clinical. I don't want to say anything bad about that person. It's the same thing about patients just in general, right? My biggest pet peeve is when someone says, well, the person didn't complain. Nobody complains. Nobody complains. You just want to get out of there, right? You're just like, oh, I just won't come back. But it takes a lot to actually say something in the moment. So for a student to say something in the moment to a CI or even to a patient, it would be huge for them to do that. So we have to realize that they probably won't, and they might come back and say something after the fact, but in the moment, it's really hard for people to speak up. especially if they have any kind of history of trauma or abuse or anything like that. They're just going to shut down, and then, they just won't go back.
Okay, thank you.
I just want to add one thing to that, that referring back to the school will engage them in that Title IX process if that's needed as well. And so I think that's another really good way to make sure that they're getting the resources that they should.
Hello, I'd like to speak to that issue as an educator. I teach in multiple programs at Howard University. I teach physical therapists, occupational therapy students, PA students, radiation therapy students, and nursing. So we, again, approach this in an interdisciplinary fashion. So we have sessions that are woven into our life and our culture at the college. We call them brown bag sessions, and then we have a session called Ask the Dean. Our dean happens to be, her area is cultural competency, and what we have to, the issue that comes up a lot is not so much the students, of course, the student-CI relationship, but the boundary is not your concept of the boundary is the patient's concept of the boundary. So the students brought up issues where they had gone in to treat patients who the women are fully covered, and to be seen by a man, just to be seen, made her unclean or made them unclean. So you have to be aware, fully aware of the different cultural nuances in your clinical settings. And I work in a Catholic setting where I have to treat nuns. And I have to say, permission, just to see you, or just what do you want me to do as far as how can I access this part of your body? And it is a very, I think students have to be exposed to this, either have people come into your program and talk to them about these cultures that are not in their wheelhouse. Because a lot of times you can inadvertently cross a boundary and you don't even know it. And I think that's important for students.
Yeah, thank you. That's a great point. One of the things I really want to focus on too, and what I've been looking into a lot, is just communication. Like, what are you saying? Not so much even touching somebody. Like the things that are coming out of your mouth, and is your communication style or the way you're talking to your patient something that is making them perceive something in a different way? I have so many examples of patients who are sending texts or emails to a therapist, and instead of the therapist saying, sorry, this is our relationship, I'm the professional, you are the patient, we're not texting, they'll say, oh yeah, that would be really nice, sorry, I can't go out with you tonight, I'm busy. No, don't say that. I'm busy tonight I'm busy tonight. That is not, I'm your therapist. That could lead someone on a place that you really had no intention to do, right? Or you email them. Who always makes fun of me about the emojis? When you, email your patient and put a bunch of emojis at the end of your email, a bunch of smiley faces, you would be surprised a patient would come back and say, well, they put a bunch of smiley faces at the end of the email. That must mean that they're attracted to me. I was like, well, no, he's just trying to be nice. The guy's like, I was just trying to be nice. But, someone else perceived that in a way that was not what your intent was. So to really think about, someone might be fine with a whole bunch of emojis, or someone's okay with, a text message. Other people perceive it completely different because they're getting attention from you that they might not be getting somewhere else. So that's a whole nother topic. But, I really think drilling down into these smaller things, that everybody knows, okay, a patient comes in your clinic and you have sex with them in the clinic. That's not okay. Pretty much everyone knows that. But all the other things that kind of lead to that place, I think it takes a while before people understand that you're getting there. Thank you all so much for coming. I really appreciate it.